All right, let's dive right into this explainer. If you've spent, any time at all in an ICU, or if you're gearing up for your CCRN exams, you've definitely run into this very specific, kind of contradictory medical order. We're talking about giving albumin and Lasix together. Today, we're using the study guide to completely decode this counterintuitive practice. We're going to break down the exact mechanism of action, figure out how to dodge those classic bedside traps, and really master this concept of the vascular sponge so you can absolutely crush this topic on your boards and, honestly, in your clinical practice too. Here's our quick roadmap. 1. The fluid overload paradox. 2. Physiology of third spacing. 3. The leaky tank analogy. 4. Mastering mechanism of action. And 5. A cirrhosis practice case study. Let's get to it. Section 1. The fluid overload paradox, gas and brakes. So to kick things off, let's tackle this apparent clinical contradiction you're inevitably going to face at the bedside. Picture this. You're looking at a patient's chart, and you see an order to give albumin, which is a volume expander, followed immediately by furosemide, or Lasix, a really potent diuretic. It feels totally backwards, right? I mean, it literally feels like you're pressing on the gas pedal and the brakes at the exact same time. Why on earth would we give fluids to a patient we are actively trying to diurese?
Well, the answer really boils down to this. It's not mixed signals, it's strategy. As we're going to see throughout this explainer, you simply cannot remove fluid that the kidneys can't access. The strategy here is actually brilliant, yet super simple. You've got to fill the tank, perfuse the kidney, and only then can you actually diurese that excess fluid out of the body.
Section 2. Physiology of third spacing. Where's the fluid?
Now, what's really fascinating here is how we break down the core problem, because this is mainly a fluid redistribution issue, not just a matter of making your patient pee. We're talking about third spacing. That's a state where fluid is literally everywhere except for the bloodstream. You might walk into a room and see a patient who looks incredibly volume overloaded, right? They've got generalized edema, they're super puffy, you hear crackles in their lungs, but intravascularly, inside their actual blood vessels, they are bone dry. The fluid has shifted completely out of circulation, which means their actual circulating volume is way too low to perfuse the kidneys.
To understand exactly why this happens, we have to revisit some normal physiology, specifically Starling forces. The MCAT and CCRN exams absolutely love testing this. Think of fluid movement across your capillaries as a giant tug-of-war. On one side, you've got hydrostatic pressure pushing fluid out of the capillaries. On the other side, you've got oncotic pressure pulling fluid in. And albumin? Well, albumin is the major plasma protein responsible for that oncotic pull. So if you're dealing with a low albumin state, like in severe inflammation, sepsis, or malnutrition, you lose that plasma oncotic pressure. Hydrostatic pressure wins the tug-of-war hands down, and fluid just leaks right out into the tissues, causing all that severe edema and third spacing.
Section 3. The leaky tank analogy. Understanding shock. Comparing fluid status across different shock patterns is an absolute goldmine for your exam prep, especially when you use a really simple tank analogy. In hypovolemic shock, you just have an empty tank. In cardiogenic shock, you've got a full tank but a totally bad pump. In distributive or septic shock, the tank leaks. But here is the kicker. In low albumin states, the tank also leaks, but specifically because of that low oncotic pull we just talked about. The fluid simply will not stay in the vessels.
So the absolutely crucial point here is avoiding this classic ICU trap on your exams. An edematous patient does not equal an adequately volume-filled patient. Just because your patient looks, quote-unquote, wet and has crackles, does not mean their blood vessels are actually full. In reality, they're likely severely intravascularly depleted.
Section 4. Mastering mechanism of action, albumin and Lasix.
All right, now that we know the fluid is just hanging out in the wrong place, let's decode the pharmacology and understand exactly why the sequence of these meds matters so much. The mechanism of action here is sequential, and honestly, the order is everything. Step 1 is albumin. Think of albumin as a giant vascular sponge. When you give it IV, it rapidly bumps up that plasma oncotic pressure and pulls that interstitial fluid right back into the bloodstream, beefing up your intravascular volume. It basically opens the door. Step 2 is Lasix. Now that the fluid is actually inside the vascular compartment, Lasix can go to work. It targets the sodium-potassium chloride transporter in the thick ascending loop of Henle, blocking it. This drops sodium and water reabsorption, which pumps up the urine output. It takes the trash out.
To really grasp this, let's think about the hemodynamic state right before you give the albumin. You've got low oncotic pressure. That means low intravascular volume, which leads to low preload, low cardiac output, and crucially, terribly low renal perfusion. If you just push Lasix without the albumin, you literally have no intravascular volume to carry that Lasix to the nephrons. And if the Lasix can't reach the kidney, there is zero diuresis. The albumin restores the intravascular volume so that renal delivery of Lasix is actually possible.
Section 5. Cirrhosis Practice Case Study. CCRN Practice.
Okay, let's put everything we've talked about to the ultimate test with a classic clinical scenario. Imagine this question. A patient with cirrhosis receives albumin and furosemide. The nurse expects A. Albumin causes diuresis. B. Lasix increases oncotic pressure. C. Albumin improves intravascular refill before diuresis. Or D. Both decrease preload immediately. Now, remember our physiology here. Cirrhosis is a classic example of a low albumin state, which directly leads to decreased plasma oncotic pressure and severe third spacing.
And the correct answer is C. Albumin improves intravascular refill before diuresis. Let's break down why the others are just wrong. Albumin does not directly remove fluid or cause diuresis itself. It simply shifts that third spacing edema intravascularly so the Lasix actually has something to work with. And Lasix definitely doesn't increase oncotic pressure. For your exam memory, just lock this one simple phrase into your brain. Albumin equals refill the tank, Lasix equals empty the tank.
As we wrap up this explainer, I want to leave you with this advanced level of ICU thinking. The very next time you're standing at the bedside of a heavily swollen, edematous patient and you find yourself reaching for that diuretic, ask yourself this. Is the fluid actually in the right place to be removed? Can I get fluid into the circulation before I try to force the kidneys to excrete it? Master that single question and you're going to master both the physiology and your CCRN exams.